Good morning. We'll be starting our webinar shortly. We'd like to hear from you. So while we're waiting before the webinar starts, you could either use this QR code with your phone and start filling out a survey, or you could go to the chat box. There is a link and you can do it on your computer. We'll be starting the webinar shortly. Thank you. Good morning. We'll be starting the webinar shortly. Hopefully you will be able to give us some feedback and give us some information by using this QR code. You can scan a picture with your phone, or you can click on the link in the chat box, and that will take you to a form, which will also be able to allow you to fill out the questionnaire. We will be starting our webinar shortly. Please hold on. Good morning. We'll be starting the webinar shortly. If you could, we want to hear from you during this interactive webinar that will start in a few minutes. Please use your phone and this QR code. It will take you to our survey, which we'd like you to help give us some information on, or you can click the link in the chat box that will also take you to the same form. The webinar will be starting shortly. Thank you. We'll be starting the webinar shortly. However, we want to hear from you. Please use this QR code scanned with your phone and fill out the form that'll take you to that. Or you can hit the link that's in the chat box on the side panel. That will also take you to the same form. If you could complete that, that will help us prioritize our network efforts to help the health centers. Thank you. We'll be starting the webinar shortly. Good morning or good afternoon, depending on what time zone you're in. Welcome to Health Choice Network and Alliance of Chicago, preparing communities for COVID-19. We're very happy that you could join us today. Hopefully this will be a very interactive session. We're going to be allowing participants to both ask questions through the chat, but then also we want to get your feedback from a form that we have developed that will allow us to prioritize some of our efforts. So during this interactive session over the next hour, all of the participants have been muted during this session because we have a number of people. But we do want you to be able to give us feedback by using this QR code. There's two ways that you can give us feedback during today's session, and we'll keep this open after the webinar closes. If you scan this QR code with your phone, it'll take you to a link where you can fill out a survey that will allow us at both networks to be able to do some COVID planning for work at the health centers, or you can click the link in the chat box that is on your screen on the right-hand side. So again, welcome. My name is Tim Long. I serve as the Chief Clinical Officer, both Health Choice Network and Alliance Chicago. And today's webinar on COVID-19, we hope will be interactive, informative, But most importantly, we want to hear from you at the health centers, what you have been experiencing over the past week or two or more, and then also how we as a collective group of health centers can come together and work collaboratively against the COVID virus. So today's programming is going to have a number of individuals speaking. And first, we're going to turn it over to our two CEOs, the CEO from Alliance Chicago, and then also our CEO from Health Choice Network. So first, I'd like to introduce the CEO from Alliance Chicago, Dr. Fred Rockman. Fred, have you joined us today?
I have been. Can you hear me?
We'll give, yeah, Fred, if you could speak up just a little bit. You're just a little bit muffled.
Yeah, hoping for the best here. So just want to be brief. Just the observation that to most effectively deal with the COVID situation, we need to be sure that efforts at every level make best use of our individual and collective limited time and resources. And that means that we need to work together to avoid duplication or waste. And we also need to organize to assemble an overall coordinated public health strategy out of the disseminated community level delivery points we represent. As older networks, Health Choice and Alliance Chicago were founded with the vision of creating shared infrastructure that would allow the health centers to remain autonomous and responsive to their particular communities, while at the same time allowing us to come together to act as a coordinated system, and also to have access to shared supportive services at scale and sophistication. Our two networks have begun to work with other parts of the health system to identify opportunities we have to use this infrastructure that we have developed over the years and our collaboration to help organize a coordinated strategic response. We want to listen closely on the call to understand how this can be best helpful and to prioritize the greatest opportunity and need. So please speak up.
Great, thank you very much, Dr. Rockman. We appreciate those words. Next, let's turn it over to Alex Romeo, the CEO of Health Choice Network. Alex.
Thank you, Dr. Long. Thank you, Dr. Rockman. Good morning, good afternoon, everyone. First of all, I'd like to thank all the FQHCs, primary care associations, health center control networks, National Association of Community Health Centers, HRSA, and the Bureau for gathering today. We know they're very busy right now, and coming together is what we have to do today to assist you further as you deal with this event. The ACN Board of Directors, FQHC CEOs, created 6 years ago for this very health centers must work together, great care system in the world, and together today assist you and further our past experiences, health information technology management, our emergency management. So as Fred mentioned, us to strategize
hopefully, people who are going to on moment. We do hear people are having a challenge audio. So we're going to ask our first presenter, Dr. Ron Yee. Ron, if you could start your presentation, and then we will go into the other speakers after that. So Dr. Ron Yee.
Sure. Can you hear me, Tim? We have...
Officer.
Oh, go ahead.
Yes.
Can you hear me? Incoming back. Hello, Tim.
On.
No?
Hello, Tim. Can you hear me? I'm back on.
Yes.
Can you hear me? Hello, Tim. I'm sorry. I am not hearing anything. I called back in. If you can hear me, I'll go ahead.
Ron, why don't you?
Can you hear me? Then, thank you for having me join you, Alliance Chicago, HCN, and Tim. And I just want to first of all let you know that we're with you on the front lines from the national level. We understand the long hours and you're working and the stress you're under, thinking about your own families and still wanting to take care of our communities. So please take care of yourselves and stay on the front lines. At the national level at NAC, we're seeking to really do our best to align the efforts with our federal partners, the provision and distribution of additional financial resources and supplies, and really creating ways to share what other health we're all experiencing on the front lines. So just wanted to let you know that first of all. And second of all, I want you to let you know, anybody that's been in the health center world, I've been in health centers for 26 years. We know how to do this. We're on the front lines. We're the responders to hurricanes, floods, H1N1, SARS, MERS, Ebola, and Zika. And so we know how to adapt to these situations, and we're very resourceful. We know how to work with our partners. So really, if you look at this, we're switching into more of a wartime situation. So first of all, I want to say for these local strategies, you really need to keep people on the front lines. When we're in a battle, we need to keep our soldiers on the front lines. So protecting yourselves and staff are key. We are no good to our patients if we get sick or we're taken out for 14 days. So please be extra careful and make it routine. When you put on your PPE, make sure you do it well. Check each other often on your strategies and how you do that. I remember doing obstetrics as a family physician. I treated every single patient as if they had some kind of infectious disease. So I practiced very strict infection control when I put on my gowns, my masks. So be sure when you're donning and doffing, you do that right. Number two, segment possible. If you can set up a tent house or an extra administrative ways to communicate. I know many of you have done this, but use that to the utmost. Texting, calling, FaceTiming, having patients stay in their car until they're ready to be seen. Doing everything ahead of time. If you can triage and sort those people out before they even get to your health center, that would really minimize the exposure. And, you know, most of all, still get the job done, do it with quality and compassion, but protect yourselves, use these local strategies, and I'm sure you're learning from each other. Number two, one is professional funding. I think NAC really gave some good input. Steve Carey worked hard to get that $100 million into that, the first thing. I know relatively. Please talk to your CFOs, and I would recommend if you dig into your emergency operation plans, which we should all have, get into your recovery mode section and look for those forms to really capture the additional costs you're incurring because of this response, whether it be staff time, supplies, tents you have to buy, additional equipment. Please document that, because when the funds come out to cover your extra costs, that will be how you document it and you get reimbursed. So please do that. State, Florida, that has actually gotten into the national stockpile. So I dug into this and found out it really comes down to working with your primary care association and your local department of health, public health, and your coalition that exists in your state. So if you have contacts with those people, please use those means to be able to elevate your needs. So document what your needs are, estimate how much you have, and then let them know when you're going to be running out. Another suggestion, which I heard from the field, is actually working backwards. So if you have an every 2-week allocation, determine how much PPE you have, and then work backwards to figure out how much you have per day. So if you have to spread that over 2 weeks, figure out exactly how many you're going to use, and then make your systems fit that so you don't run out. You need to protect your staff and their clinicians. So you can use that as data and information when you're called upon to report this to probably the PCA so that they can use this to gain additional equipment through the national stockpile that is designated for each state. Please also do everything possible to use your PPE wisely. So I heard of one health center that was using, 4 to 6 sets per patient. So please start coupling duties. Someone's going to do, they had people doing registration, vitals, seeing the patient, sending them to the lab, and then the patient themselves wearing an N95 mask if they were symptomatic. So compress that down. Have one person do a lot of those things if you can, and save your PPE. We're also working with relief agencies and funders that have been calling us to find additional supplies for you all in the field. So please use it wisely. The other thing, I just got off a call. Some are working with their local construction companies and even private dental offices, and asking them if they can contribute some. So one health center had, 4 large boxes of N95s from their local construction company. They also had 4 to 5 cases come from dental, shifted from their own, but also from private practices. So please use your local relationships. So those are the main things I wanted to talk about in terms of strategies, funding, and PPE. Again, we are trying to work our best at the national level to find more for you. Next steps, our policy staff are continuing to give input on the second and third rounds of funding to the congressional members to ask for a congressional support for supplies, surge staffing, covered paid leave, and tax credits for health centers. We're also working directly with Quest and LabCorp to identify where these drive-through testing sites are. Some of you have those. I believe there's 7 to 10 states that are doing it now. If we can identify where those are geographically, we can let you know so that you don't use all your staff up in your PPE doing testing if you can send them to a local person group. So that could be the public-private joining of Walmart, Target, whoever it is. So we're trying to find out who those are. We're also communicating with different philanthropic disaster relief organizations to really understand their distribution practices and to give them the information they need to know who really needs more PPE and other supplies. Tomorrow, we're starting weekly updates. We're collaborating with HRSA, the Bureau, the CDC, and health centers to give examples of how to do these things, which I know you will cover on this call, and Tim's going to go further on PPE. But we are starting tomorrow at 1 o'clock Eastern time. We'll give the connection information later this afternoon. It was short notice. We pulled this together. We will have Jim McRae on there. We'll have the CDC on there and Tom Van Coverdin. So that'll be a weekly thing. If you're clinicians and you're working and you can't pull away, we will have the recording and transcript available very soon, right after each webinar. And we're looking at doing a series of these, walking through operational and financial aspects of responding to such as this. And finally, I think I need Alliance Chicago and HCN clinicians. You guys are the innovators. Please figure out how to best attack some of these problems with triage, with stretching out PPE, with doing with your supplies, and innovative ways to take care of your patients. And we can't forget about our patients who are still out there. So if you are using telemedicine to stay in contact, if your state can bill for that on the Medicaid side, I know they're trying to get Medicare to cover that. It came out yesterday that they're going to loosen the rules on telemedicine for Medicare. Right now, FQHCs are not included in that. So our policy staff, as well as HRSA, are working on getting that included. So, but if you are in a state that takes Medicaid telemedicine, please optimize that to stay in contact with your patients. So again, know that we're with you. I think our goal is to flatten that curve that Dr. Fauci is speaking of often. We want to get that incidence down, especially these next 2 weeks. So stay healthy, stay on the front lines, and know that we're with you. So thank you, everyone, and just stay on the front lines.
Great. Thank you very much, Ron. We appreciate your words. And hopefully many of us can join the webinar tomorrow with NAC and others, and we appreciate you extending the invitation. And today we have many clinicians on the line, so I know, Ron, you'll be staying on. We are going to ask that people ask questions in the chat, and we'll be monitoring that chat as we go through. So hopefully we will have some questions for you later on, Ron, when we get into the question and answer session.
Okay, thanks, Tim.
Great. Next, we're going to turn it over to a couple of our health centers, and we're going to hear from some health centers on the front line who have been working within their locations to determine different policies, procedures, workflows, and practices. So first, we're going to hear from a health center, community health center of Pinellas, and I believe we have both Dr. Threadgill and Dr. Kelly on the line, and they will unmute themselves, and we will hear from them. Dr. Threadgill, Dr. Kelly?
Yes. Good afternoon, everyone. We are both here. Hi. So good afternoon, and thanks for giving us a couple of moments to share our journey as we kind of move through COVID-19. So what we at our organization kind of did was we started about 3 or 4 weeks ago with our emergency response team started meeting. And at those initial sessions, it was really just forecasting and predicting based on some of the information that we had heard and garnered through multiple sources. And so we started at that time to really identify any potential areas that could present challenges to our workforce, to our offices, and barriers to us providing care to patients. So some of the things that we identified included inventory. Of course. And so that was our PPE supplies, that's our cleaning and disinfectant supplies, equipment, testing supplies. And we started at that time trying to identify exactly how much we had on hand at the centers. We started an inventory, kind of a consolidated inventory schedule, and we monitored our ordering patterns and started to really hone in on how we ordered and what our ability to receive supplies were. And so we put that on a list that we would survey, and we surveyed that weekly initially. And then we started to then restrict some access to some of those supplies and needed equipment, because we realized that we didn't want overuse and we didn't want redundancy in programs, as Dr. Yee mentioned in his presentation, that 4 or 5 people go in to kind of do the same thing with the patient. So we started to try and work on those processes early on to avoid unnecessary utilization. Then we started looking at our exposure precautions and our clinical procedures and try to identify how we can keep our employees and workforce safe, how we can keep our patients safe. We then developed some clinical protocols based on the recommendations from the CDC and the screening questionnaires from the CDC. And we started then to train our staff, because when you change things in workflow, you have to try and make sure that everyone is on board and everyone understands why it's important. When we initially started, coronavirus was not in the news every moment, every day like it is now. And so why are we doing something extra became, somewhat of something that we had to kind of train and educate our staff and our team to make sure they understood what was going on. So we did a lot of training on donning and doffing for all of our clinical staff, training on how to ask screening questions, what to do when a screening questionnaire is positive. And then we had to create some protocols on how to manage patients as they meander in and out of our teams and in and out of our centers. We identified isolation rooms in all of our centers and geared them up. We discussed with our facilities team, donning and doffing. We went through with our facilities team appropriate cleaning and high touch and low touch cleaning. And so we had to build protocols for all of those things so that everyone had a clear expectation of their responsibilities, and to really try to protect all of the team members and all employees as best as we could. Then we started looking at workflow and how could we make changes in how we provided care that would limit exposure and limits people in and out, and we could do a little more social distancing. And so we then started working on protocols for phone visits and phone messaging. I don't know, we are under the emergency rules, I guess, with telemedicine. Florida is one of those states that we do not get reimbursed traditionally for telehealth. And so we started, though, working on how to best conduct visits telephonically. And so we had to do some work with our team members, providers, and all on how we could do that if we were able to. So we started that information a little bit earlier. Let's see. Then we started looking at another challenge of ours, which we knew would be workforce. And so we know that when schools close and businesses close, such as daycares, et cetera, that would be a challenge to us as far as workforce. So we started then to survey our employees. In addition, this is spring break time for our area, and so many schools are on spring break or were on spring break. And so we were already, faced with some limitations in workforce, but combine that with, and we don't have childcare and others, we knew that we had to kind of look at some creative strategies for working on that. So we put that in the think tank and really tried to work on how we could do that and how we could best do that, and came up with some ideas and some possibilities in the event that we would have to get to the point where we would really have a decrease in our workforce. And then, of course, our other great challenge, as I kind of alluded to, is just kind of regulatory restrictions. And so televisits and remote visits, how do we get PPE? How do we get testing media to provide tests? Prescriptions, and so how do we refill medications? Some of those things were lifted with the emergency order, but others are still a bit of a challenge, especially as we're working through things such as electronic prescribing of controlled substances and trying to get all of our providers ready. I know that we were all kind of working on that and preparing for that for other reasons, but now we need it to be completed. And so we still have some that have it and some that do not. And so that impacts, sometimes the ability to provide care from a virtual environment. Let's see. So what barriers are we still facing? I think they are still very similar. We've created ways to work in the now, but I think that as we look forward, we still see the challenges with workforce. Things are getting more and more restrictive. And supplies become an issue for us. While we were able to, fortunate enough to kind of have a nice supply, we know that replenishing that supply has become an issue. And so the ability to practice safe infectious and exposure control is difficult when supplies are thin. And so we want to make sure that everyone is safe, but we would need additional supplies to do that. Additional supplies for testing, because again, that we right now probably have enough equipment to do maybe 100 tests or so. Needless to say, we had 100 patients diagnosed positive in our county, yesterday, was it not? I mean, we increased by 100. So we need a lot more ability to test patients. Equipment for IT. Many of our team members had laptops and home access, et cetera, but certainly many did not. And so we had to do a lot with preparing all of our team members, identifying who could work from home, looking at alternate ways to perform duties so that they could work from home to do that, but getting them ready with licenses and all the things that they need to be able to do that. And so we're still working on those and making sure that everyone has equipment that's appropriate. So that has been our journey through all of this. And so we have in the past, I don't know, few days, changed our workflow quite a bit, including we have added a drive-up testing option that we started and have already had some testing through our drive-through testing. We have started doing our tele-visits, and so we have providers who are able to provide tele-visits to our patients. We are screening all patients when they call in on the phone, as well as before entering the buildings. And we have identified pathways for directing patients to limit exposure as much as possible to employees and other patients. Yeah.
Great. Thank you very much, Dr. Threadgill. We appreciate all the work that you're doing at Community Health Centers of Pinellas and all the health centers that are working so hard on this. Many are sending in questions through the chat. Please send them in. We probably will not get to answer all of the questions that go into the chat. However, we are going to be cataloging all the questions that are put into the chat, and then we will be providing answers later after the webinar if we cannot verbally get to them on the webinar. And one of those questions I'll just read, and then maybe our colleagues, Dr. Yee or our colleagues at HRSA, who I know are on the phone. One question is, that we don't have to answer now, but just want to prep you for, is, quote, can you go into more detail on the loosening of the HIPAA regulations? The guidance that came out yesterday does not apply to FQHCs. So maybe after we hear from our presenters, we might want to have Ron or Suma, if that's possible, to help us with some of those questions. So next, we're going to turn it over to another one of our colleagues at our health center, and that is Miami Beach Community Health Center. And I believe we have Dr. Torres on the line, who's going to talk with us about efforts that our health center in Florida, Miami Beach, has been doing. Johan, are you with us?
Yes, I'm here. Can you hear me?
Yes, we can.
Perfect. So thank you, everybody, for attending and asking me to present on this. I think Dr. Threadgill did an excellent job in presenting her center's efforts. I'm gonna probably repeat some of the things that she says. We've done some things that are very, very similar, but I think it's important to hear it from different perspectives. So, we were similarly to Pinellas, we started looking at this really in early February, late January, when HCN put out in their forms menu that we use in the EHR, a screening form for COVID-19, at that time just being called coronavirus. And we enacted that probably again like late February, early February. Around exactly 3 weeks ago, actually February 26th, is when we started following guidance from the Centers for Disease Control and others in the Department of Health. We put together a task force comprised of Suranji Menjivar, who's our chief operations officer, myself, the nurse supervisors, and our environmental care and safety director, among others, including Dr. Rubinowitz, our CEO, to try to deal with the emerging crisis. At that time, really all we did, and that was just 21 days ago, it feels like a year ago, a workflow to deal with patients who come in. And again, at that time, screening was done based on travel only to China on that date, and presenting with symptoms. We were at that time having the patient care staff, the front desk staff, screen these patients. And maybe several of you, I'm talking about this because maybe several of you are still at that stage where you're having front desk staff. We have changed that since then, and I'll discuss that in a second. We were, as Dr. Threadgill mentioned, we were designating isolation rooms within the clinical areas where we could put patients who meet criteria for testing. And at that time, we ran drills at each center to try to work out any snags, to see what would come up if this happened. We actually had a false alarm on that day that we were doing drills, where a patient had been exposed to her boss who had come from China, and no one had symptoms, but it was right in the middle of running drills. We actually got that false alarm. We noticed at that time, again, as Dr. Threadgill mentioned, that we had limited supplies. Prior to this whole crisis, Miami Beach Community Health Center, we typically will put a mask on someone who comes with any URI symptoms to protect our staff against influenza. And we had to kind of change our thinking and change our workflows as of then. And I'll just tell a quick anecdote that at that time we had the false alarm. It went through that clinical area in less than 2 minutes. I mean, 15 people had masks on before we even got to see this patient. So that I'm saying that to bring out the point that we had to do a lot of staff education about what's appropriate and what's not appropriate. So our clinical protocol, as far as dealing with patients who come in who are at risk or who we think that might be candidates for testing or persons under interest, I won't go through all the steps, but they changed literally daily, including today. We did start what we're pretty much doing today on March 13th. So we decided on that date or the day before that we were going to start screening patients outside of the clinical area. So we do as Dr. Threadgill said at Pinellas, we do entryway testing. So even before they get into any of our buildings, we do screening at that point to see if they are a candidate for testing. We initiated our drive-up testing protocols and availability. So patients who call us on the phone and seem like that they are at risk or that they are candidates for testing, we leave them either in their car, or if they're coming a different way, we're having them sit outside in a tent that's away from the entrance of the building. We initiated a phone protocol for screening and an in-person protocol for both those things, based on what has been passed around. So my next point is the importance of the network. So because of a forum that we have among the clinical leaders at HCN, we have been able to exchange ideas, documents, protocols, etc. I want to thank Dr. Yobes from Camilla's house for initiating a bunch of questions, and then Dr. Long and others at HCN put that into that conversation into a forum. So we were able to see what other people were doing, share what we were doing, and take from that and apply it to our center. So our current protocols are based on those. I want to thank Dr. Threadgill again, because a lot of our protocols today are based on what she had put out a couple of days ago. I also want to thank Tony at CHI, if he's on the phone. The idea of putting together a FAQ, frequently asked questions, came from him, and we're working on that as we speak. I think that's important, more so for our staff, so they know what we're doing, so that it's more education, so that there's calm, urgency, but calm among the staff. And perhaps that might be helpful for patients as well. So we're working on that. That's in progress. So a couple other things that are in progress as far as our workflows. The main things we're working on now, and these are not set yet. Again, every day is essentially consumed by this, and we're trying to address these issues. How do we assure patient safety? So how are we going to deal with non-essential visits like checkups, non-essential or non-emergent dental visits, immunization visits, etc.? We are in the process of making decisions about that and trying to figure out what we're going to do with those patients. If you know Miami Beach Community Health Center and you've heard me speak before, we are big with calling our patients to come in for their pap screenings, their fits, getting their immunizations done. We have a big prep program, etc. These are non-sick visits. How are we going to deal with this? How are we going to make sure that the patients get what they need, but also keep them safe in this environment that we have, especially since we've been identified as a testing center, which I'll discuss in a second. How do we deal with refills? Patients, if they don't have to come to our pharmacy, we have a pharmacy at each of our sites here at Miami Beach Community Health Center. We're working on our workflow right now to try to do as much delivery as possible. Ship patients to our mail service or our courier service, fill 90 days if possible. But questions that come up and the challenges in this setting, how do we deal with collecting, or do we even collect co-pays, uninsured patients? How do we deal with that if they are not in person in the pharmacy? So that's not something that's in progress. We literally started putting that together in this week. How do we deal with our vulnerable patients? So patients who are over 65, HIV positive, diabetics. We have a huge HIV practice. We have a lot of over 4,000 diabetic patients last year. We have a burgeoning opioid program. These are patients who are used to having regular visits, might need to have a physician visit of some sort, whether that's in person or through telehealth. We haven't come up with a firm plan on that, but that's in progress. How do we deal with our staff at risk? I'm sure Dr. Threadgill had mentioned it, and I think Dr. Yee had mentioned it. How do we deal with our workforce? We have a lot of workforce, as most people do, who are in some sort of risk groups. How do we deal with them? And then we also have a resident student program, a very active residency and student programs. How do we deal with that? So those are all in progress. We're coming up with ways to deal with that. We're so early in really pushing through this that we haven't come up with solutions yet. Challenges that I see moving forward, staff and provider education is huge. The information that we're getting from the CDC and the health departments changes every single day. One issue that we've had is masks. There are a lot of some of our providers who feel like they need to put a mask on for everything, and that is a day-to-day struggle to try to convince them that that's not. I understand where they're coming from, but that's not currently recommended, and it's not really helpful, especially when there's a shortage of supplies. The big question we're facing right now is, who do we test? Miami-Dade County in South Florida, I just checked the Florida Health Department's website before I came on. It has the second highest cases by county in all of Florida. So that's 76 cases, and a lot of those happened in just the past 2 or 3 days. We are inundated with people who want to get a test who may or may not be symptomatic. In addition, we have been identified by local politicians, by the health department as a center that offers testing. So we are getting patients who are not even our patients coming in. How do we deal with that? Who do we test? How do we use our limited resources to address that? Patients are getting mixed messages. I'm sure we're all watching the news, seeing the health departments and the federal government giving us different messages that are a little bit confusing. Media is giving us information that's a little bit confusing. And then other things that we're, other challenges that I see we're dealing with. How do we track this? What data can we use to see who's being coming in to test, who is being exposed to those who are testing, the percentage of people who are positive, et cetera. And luckily, we have not yet had a positive test at Miami Beach. Supplies are huge. That's already been discussed. And then telehealth, that's another huge thing. We were starting to think about it prior to this whole thing. But I think we need to move forward as a network, but certainly as a center, we need to try to move forward with telehealth a little quicker than we had anticipated. So that's all I have. Thank you for allowing me to talk, and I'll answer any questions at any time.
Great. Thank you very much, Dr. Torres. We appreciate all those words and the experience. So we probably will be getting some questions for you, Dr. Torres, in the chat in just a little bit, and we'll be coming back to you in a few minutes after we get some of those questions. But I did want to back up just a little bit to remind people that in the chat function, there is a link to a survey that we'd like to hear from you. And some of those questions will allow Alliance Chicago and Health we really want to know how interested your health center is in a number of areas, such as virtual care, analytics, informatics, public health tracking, and engagement. So please go to the chat box, click on the link, and it'll take you to a form, and that will allow us, both at Alliance Chicago and Health Choice Network, to get some better understanding of how we as a network can organize to help you at the health centers. So we have a number of questions in the chat, and I wanted to address one to Pinellas and Dr. Threadgill. And this comes from another chief medical officer, and she's asking, what type of visits are you seeing in your health center, and are you seeing follow-up visits? So Dr. Threadgill, would you be able to answer that question?
Yeah, this is actually Dr. Kelly. I'm going to take this one. So when we started looking at what visits are coming into the health center, first we kind of looked at the schedules to see what could we potentially route away from the center, what would be safe to do so. So we looked at visits that could be converted to televisits, such as lab follow-ups, medication refills for stable patients, referrals, et cetera. And we also then routed well child checks to 3 designated centers. So we took sick visits out of 3 centers and made them well centers only, with the priority to get infants and babies under the age of 2 in, because they're still a at-risk population for other reasons, needing vaccinations and whatnot. And then we looked at what was left on the schedule then. So that remained, the acute conditions. So obviously, as a community health center, our patients still have other reasons to need to be seen in the office. And so those kinds of acute conditions that need an exam or need vitals or need some assessment is what was left.
Yeah, things like chest pain or abdominal pain that, you can't really rule anything out via the phone. You actually have to examine a patient. I would say, shortness of breath if you're stable, but, history of COPD or something, and you're having some issues and we maybe need to do a pulse ox or something like that. So conditions that actually need some physical management, we felt we were the ones to see them. We can't send them to the ER. They don't have conditions that warrant emergent treatment. And we are still here to provide care and serve our communities. And so we wanted to make sure that we did have access for patients who we felt needed to be seen. So, those are the providers and clinical staff and all that are in the buildings have the PPE that is necessary in case there's any concerns. And so we still see patients. We did, though, decrease the number of patients on the provider schedule, trying to avoid congestion in the waiting areas. And we've given patients the ability to wait in their cars, and then we can call them to come in when it is time to room them. So we did move with the goal of trying to limit the number of people hovering in any one space, but still wanted to make sure we were available to provide care for patients.
Great. Thank you very much, both Dr. Kelly and Dr. Threadgill. So we have a number of questions coming into the chat, which is great, and we are getting some responses onto the survey in the chat link. Appreciate that. We would like to hear if Ron Yee, are you still with us? We have a couple of questions if you're available. Great, thanks, Ron. Let me read a couple of questions, and they kind of roll into a lot of questions are being asked, but it's on the area of telehealth. And Chris Russell is asking, we need clarification for getting reimbursed for telephonic/video calls for FQHCs at this time. What do you feel that health centers should do now on both telephonic and video conferencing telemedicine?
So the first thing I would do is go to CMS, so www.cms.gov. They just put out 3 documents yesterday. That includes a description of the general rules, fact sheet, and then they have an FAQ. And so I think that's the starting point. The second thing is to either talk to your PCA or maybe your CEO or CFO knows that if you're in a state that will cover Medicaid. So this is specifically for Medicare, but that's the starting point. So find out if your state, I think there's 31 states that will cover telemedicine for Medicaid. Second of all, so this is Medicare specifically. So that's the starting point is knowing whether your state reimburses for it. If it does, then you have the option to look at Medicare. Now, as I said earlier, they're working through that. I spoke with our policy folks, and they said that to this day, the FQHCs are not included in the Medicare loosening of the telemedicine. So we spoke with HRSA yesterday, and they agreed that we need to ask some questions of Congress. They need to loosen that for the FQHCs and the RHCs. You had an earlier question specifically about HIPAA, if you do telemedicine. And in that same document, I think it's towards the last page actually on the fact sheet, it talks about HIPAA. And so specifically it says that HHS Office of Civil Rights will exercise enforcement discretion and waive penalties for HIPAA violations against healthcare providers that serve patients in good faith through the everyday communications technologies such as FaceTime, Skype, during the COVID-19 nationwide public health emergency. So according to that on the last page, they're loosening the rules around HIPAA. So you can use things like FaceTime or Skype And I believe that would include like texting and other ways you communicate. So now that's for Medicare. So I'm not sure if that applies to the Medicaid visits as well, and we would have to go further to find that out.
Great. Thank you very much, Ron. Appreciate that. And we have a number of other questions that are coming into the chat surrounding that. So I would strongly encourage people to join the NAC webinar tomorrow, where more of that guidance will be coming out. And next, we're still monitoring the chat. A number of questions are coming in, but we're going to turn it over to another one of our partner health centers, and we're going to talk about drive-through testing, which a number of health centers have been putting up. I believe CHI was going to go live with drive-through testing, but now we're going to hear from our colleagues Chris and team at Found Care. Chris, can you hear us?
Yes, I can. Can you guys hear us?
We can hear you loud and clear. Thank you.
Wonderful.
Hi, everyone. I'm also here with Chris. This is Dr. Onika Mary. I'm the Chief Medical Officer here at Found Care.
So we just wanted to share a little bit of our experience with the drive-through testing, how we got to this point. My perspective will be a little bit more on the administrative end and how we set up sort of the back operations, and then Dr. Marriott will speak a little bit on the clinical end. You know, a couple of weeks ago, we started to meet and plan on what it was we needed to do to address this particular issue in this pandemic. We obviously knew, being a community health center that has about 300 to 350 people coming in every day to our main site, that at some point we would be impacted. And so we started some early planning and some discussions on how we would address it. And of course, as time went on, we started to see that some private providers in the area, even some public health and other health centers in the area, were sending patients to us with prescriptions that said test for COVID-19. Of course, that presented a challenge for us, and we already had plans on meeting patients outside at the front door, putting, you know, signs in the front door, and having a security guard and some clinical folks in the front door to sort of triage patients before they walked into the health center. So we had that set up, and we started that process in the latter part of last week. And then over the weekend, we were in constant communication and talking about the fact that, you know, someone needed to step up in the community, and particularly the county, because the influx towards the latter part of last week really started to grow, and people were just kind of getting desperate. And so over the course of this past weekend, we came up with a plan. We set up a phone number where folks can call and set up an appointment to come in to a drive-through testing site in our parking lot. So over the course of the weekend, we set up the phone number. We made certain that, you know, first thing Monday morning when we got to the office, we went ahead and set up a phone bank, and we had that set up. Our IT department's fantastic. They set it up in about 59 minutes. I don't want to say an hour. It was amazing. So we set up 10 phone stations with computers. We set up an appointment system outside of our regular EMR to make certain that we weren't calling folks more than once or whatever the case may be. And we also set up a system by which a patient would have to call for an appointment. Once we called back, they would be given a code. They would be screened, I should say, first, of course, most important of all. We were screening folks to find out if they had symptoms or had been in contact with anyone with COVID-19. And we also developed the criteria, trained the staff that was answering the phones or actually calling folks back, and then created the appointment system for them to get appointments to drive through. Our first day, we received 6,000 calls because we had a press release announcing what it is we were doing. We are up to 12,000 calls that have come in. We have since gone out and told and changed the dynamics of that by telling folks that, you know, due to limitations, we have to scale back what it is we're doing. So now we have about 4,800 voicemails that we're returning the call for, and we're screening. And The first day we screened on Monday 65 folks. No, I'm not sorry, tested 65 folks. The second day we tested 41 folks. We took a reprieve today, so today there is no testing going on. We're gonna re-engage tomorrow, Thursday, and Friday of this week. Next week, we're changing our schedule to just Wednesdays and Saturdays. And I think what we really wanted to do, and I want everyone to understand the rationale behind this. Realistically, there was no place for folks to go, and FQHCs, we've been on the front line of everything. And for those of you that are on the line, no, we're on the front line with the opioid crisis. We're on the front line with so many other different HIV. We started as an HIV organization, so we felt compelled to help and to make a difference. And now, luckily, because of what we've done, we're starting to see other testing sites. Now some of the testing kits are coming to the private physicians and to urgent care centers. So as we start calling patients back, they're saying, oh no, my urgent care center called me, or my provider called me, and I have other testing opportunities. We have appointments scheduled out till May 18th. And of course, some of our concerns are we gonna have more kits? Because we receive so much publicity, there are folks that have stepped up to the plate like Quest Diagnostics and given us access to more kits and so on and so forth. But it is a case-by-case basis, and we've been very clear that this is going to continue until we have no more supplies left. So I'm going to turn it over to Dr. Marriott to speak a little bit about the clinical logistics and how she's directed the team.
Okay. Good afternoon, everyone. So just much like everyone has spoken before, a lot of planning has gone into this, and I know a lot of our centers have really been working hard on this. With regards to the initiative, we actually utilize some of our prevention staff, all of our prevention staff that is used to being out in the fields and doing HIV testing. We utilize them on for the drive-through, or the drive-up. And so with that, our teams would consist of one person dedicated to tagging and bagging. So we make sure that we capture the patient's information appropriately, as well as bag that. And then the team would be divvied up for those that go up to the car and ask the questions. I created an intake form that captures demographics, some key risk factors. We also added in race and ethnicity just to capture some of that data as well too, as well as whether they're first responders or healthcare providers or over the 65 with symptoms, prioritizing those groups. So we have a set of people that will go up to the cars and screen them as they come in. We're also verifying for those with appointments that we have the appointment code. Of course, as you know, a lot of people showed up on that first day, and we say it was a trial run, but we wanted to capture as much people as we could, so some didn't have appointment, but we really restricted that down on Tuesday to just make sure we had enough PPE to keep our staff safe, as well as enough supplies to actually perform the test. So kind of trying to keep a little bit tighter control on it. So if there was anyone that was a first responder or healthcare worker, though, that was referred to us, then we also would screen them. So our staff would screen them there, and then we would pull them into designated parking areas where at first day we were doing 3 cars at a time. We limited it down to 2 cars just to give us a little bit more space to maneuver so our staff weren't bumping into each other. And verifying all the information again. I was very strict about make sure we say it again, or have the patient repeat back to us their name and date of birth and everything, make sure we capture the right information. We were taking their temperature. And then performing the swabs. And we have, based on the supply that we had, we pulled from a lot of our own inventory from our various sites for the swabs. And then as the days have gone on, we've gotten some donations from Quest, as well as from one of our local health facilities, SOMA, dedicated some swabs to us. So we had a combination of nasopharyngeal as well as oropharyngeal swabs. And we would let the patient know, of course, this is what we're going to perform, as well as give them information about the turnaround time. There was very few people that came through the drive up in the last couple of days that I had to kind of screen out. There was just maybe a handful of those. The other ones we went ahead and we did swab, and letting them know, at least right now per Quest, for our area, it's about 3 to 5 days to get the test results back, to stay home, you know, practice that social distancing until you get your results back. So, you know, that's been the process. We've had 2 pickups for Quest in the day, and our Quest rep has been really great with that. So we're making sure that we're getting them out and they're confirming back that they've received them and that those have been shipped out as well too. So we are just, you know, we're moving forward. We have several scheduled for 20 people scheduled for Thursday as well as for Friday. But again, that can be, we can definitely add to that. Today, as Chris mentioned, we're kind of taking a reprieve to kind of regroup on everything. And however, if one of our providers in the health center, somehow they got through that front door screening and still ended up in the back and the provider's concerned after a flu test is negative, then we are testing those in the health center, as well as some of our staff who have fallen ill, just most likely with some other symptom, but we're making sure we're covering them for COVID. So we've tested them as well too and sent them home.
Great. Thank you very much, team from Found Care. You guys have had quite the experience there, and hopefully many health centers can learn from the experience that you've had. So I know we're at time. However, I think it would be helpful to ask one question of Dr. Torres, and we'll bring him on in just a moment. I just wanted to remind people to make sure that you fill out the link in the chat that goes to a scanned document that will give us feedback at the network level to help set up some programming to help health centers through this period. So make sure that you're able to scan that CR code to your phone or the direct link from the chat box. So Dr. Torres, we have a question from another one of our colleagues. Based on decreased actual person visits, are you reducing or rotating staff in shifts? And what percentage of your actual visit volume are you currently seeing? Dr. Torres?
Hi, yes. Can you hear me? It was not unmuting. Hello?
Yes, we can hear you.
Perfect. So great question. I wish I had a definitive answer. We have, over the past 3 days, certainly experienced a decrease in the number of visits that we've been having to the center. And that's before we started calling our patients to try to reschedule. A lot of patients are I guess, isolating or social distancing so that they don't want to come to the center if they don't need to. I heard one report of a patient, or at least one patient, that said that they heard that we are a testing center, so for that reason they would rather not come. So it's a whole mixed bag there. Just anecdotal, I have not looked at the day-to-day counts exactly, and I can't give you an exact number, but it looks like we're about 50% of what we normally experience, and that's really just after 3 days of this exploding in Florida, widespread at least in Florida. And as far as rotating staff, again, we have not really implemented any specific plans. Those are that option is in discussion. We just discussed it yesterday. Potentially doing unusual hours, so not just a Monday through Friday regular clinic hours, but perhaps doing extended hours, or doing we already have a Saturday clinic, but perhaps increasing that, or having other hours during the week that we normally don't have, and rotating staff through to address the decrease in volume. I'm getting information from our one of our IT people that's saying that it looks like we have about a 40% decrease, not a 50% decrease. So our patient counts are usually in the close to 1,000 a day. It's now, the past couple of days has been around 700.
Great, thank you very much, Dr. Torres. As we have received many questions in the chat, we're not going to be able to answer all the questions on today's webinar. However, one of the things that we would like to do is either have future webinars that hopefully, if this was helpful. So at the end of this session, there will be a questionnaire that pops up, and hopefully you can fill that out. And then also, we will be cataloging all of the questions that were asked and also be responding to each one of those questions in writing after today's webinar. Today's webinar has been recorded, and we will be sending the recording out. Next, we have one question. If Found Care is still with us, Chris and Dr. Marriott.
Dr. Marriott unfortunately stepped out. We had a code blue, but I will do the best I can to answer any question.
Great, thank you, Chris. Our question is, or a question that came in from Dr. Santiago is, what information is collected as part of registration process for drive-through?
Right, so right now we're collecting basic information. Name, phone number, email address, race. That's, to my understanding, that's what we've been collecting. I don't believe we're collecting date of birth. Oh, we are collecting date of birth as well. So we're really trying to collect the basic information so that obviously we can contact the patient once we have the results. And we're obviously filling out all the information that Quest requires.
Great, thank you very much, Chris. And yes, you did a good job, and hopefully the code blue is not too bad.
Well, luckily it's in the lab, so it's probably just someone a little faint from a test.
Okay. Hopefully on the screen here, as we close out today, both Alliance Chicago and Health Choice Network are compiling together a resource library. Many CMOs and clinicians have emailed me asking for policies and procedures, workflows, algorithms, and also we've sent a bunch out. Both networks have been compiling all of those documents together and building up different resource libraries. We don't necessarily want to duplicate things like the CDC, which is an excellent website to go to, but we do want to help supplement some of the workflows that might be a little more specific to each of the networks. So I know that there were some specific EMR, either Entergy, Centricity, or Athena1 questions, and each of the two networks will be addressing those questions within the network. These two resource libraries, which you can scan, will take you to the resource libraries where there will be documents that will be housed that you can pull down and hopefully utilize at your health center. We will be collecting more and more of these over time, and hopefully we'll be moving this into a format in which it's much easier for clinicians, chief medical officers, and clinical leaders to both share information, receive information, and then hopefully we'll have a blog or some type of question and answer area soon, and we're working on that. So we do have a couple of other links here. I would strongly recommend, if you're not already, but you probably are, looking at the CDC website, then your state Department of Health website. Many health centers are building up new programming on their sites and new dashboards. And then I would strongly recommend people join the NAC webinar tomorrow, which is tomorrow afternoon. So hopefully this was helpful for everyone today. After we receive feedback, if people feel that this was helpful and is sharing information for our clinical and clinical leaders, we will be putting on more webinars and interactive forums. So please fill out the questionnaire at the end. And please don't forget to fill out the forms that will allow us to talk about different programming that can help all health centers as a network. So we're all in this together, and I want to thank you for all of the work that you are doing within your health centers and the lives that we will be saving for patients that are coming into our health centers. I strongly believe that we will be looking back on this period and saying, what were you doing during that COVID virus of 2020? So please be flexible, please be patient, please be kind, and please look out for one another. So I hope everybody has a great day. I hope this was of value to you, and we'll be talking with you soon. Have a great day, everybody.